So we are good to start in another 2 minutes.
Yeah, perfect. You will introduce me and then I will start, right?
Right, sir. Right. I'll introduce you.
Yes.
It's sharp 3, sir. So with all your due permission, can we begin?
Yes.
Thank you so much, sir. Good afternoon, everyone. This is Batul from IGCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With great honor and pleasure, I would like to introduce our eminent speaker for today's session, and he is none other than Dr. Venkatraman Kulasu. Sir is the Clinical Director at the Department of Critical Care Medicine at Yashoda Hospitals, Hyderabad. With the help of Sir, we'll be taking a close look on today's topic, which is sepsis, a silent killer, basics and beyond, a case-based interactive session that we are going to discuss today. So now, before moving on to today's session, let us have a brief look on what the topic has to say. Sepsis is a life-threatening condition that often goes unnoticed until it's too late. Here, through interactive case studies, we will explore the complexities of sepsis management, highlighting the importance of early recognition, prompt intervention, and multidisciplinary collaboration in combating this deadly syndrome. So with Sir's wonderful input and with Sir's knowledge upon this topic that is going to ponder, we all are looking forward to Sir's wonderful session upon this topic. So now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. So over to you.
Yeah, thank you for that introduction, and thank you IJCP and MedTalks for this opportunity. It is always a privilege to interact with the viewers and audience. So today's topic, I'll take you this. The term sepsis is not a new entity. This has been as old as like Hippocratic time in 460 to 370 BC, where the sepsis, the meaning of this has been a rotten or something which is rotten. See, many of us in our childhood days, we come across this term called the patient got septic. The peripheral lady got septic. You had an injury, you may get septic. So this term has even been a common use in many normal public also. So it's a not an uncommon term. But the term from those days has evolved over a time, and we'll go through those on a quick time. Why we say this is a silent killer? We use the term it's a silent killer. If you look at this, common cause of annually deaths in any leading country or any developed or developing country, it's always been focused onto the coronary artery disease and stroke. And they are the leading causes as we understand. But sepsis comes one of them. 1 in every 3rd death in an hospitalized atmosphere is due to sepsis. And this is one of the leading cause of deaths in hospital settings. Most common, always the debate is, what is the difference between an infection and a sepsis? all of us in a routine terms get many infections like upper respiratory tract infection, urinary tract infection, gut upsets. Sometimes you get skin local infections like boil or a furuncle. Sometimes you also get some joint arthritis. So when do we call it as a sepsis? Is all infections are sepsis? Earlier we heard that confusion like saying ki the systemic inflammatory response syndrome, if somebody has a fever or a hypothermia, or somebody has a tachycardia, or somebody is breathing harder, washing out CO2, or had a leukocytosis or a leukopenia with immature band forms, if two of them are present with a suspected infection, we termed used to be them as a sepsis. But the problem there was many of us who actually have any regular infections in the form, if you say, I have an upper respiratory tract infection, I will do have some fever. I may have a tachycardia related to that fever. I may be tachypneic because of that fever. But just because I have a flu or I have an upper respiratory tract infection, do I need to be labeled as a septic patient because I have a proven or a suspected infection in the form of flu by a virus? And then I have two of these criteria which are fitting. So this is somewhere not going well for last few years or so. I will go through a case to just understand how this systemic inflammatory response syndrome can be a common phenomenon in many situations. Let us go through a patient who admitted to us with a 27 years old in the emergency room with a history of fever, abdominal pain, vomiting for the last 5 days or so. And this patient also had an abdominal discomfort and distension. And he gives a complaints of decreased urine output for the last 24 hours or so. And in the last couple of hours, he's more breathless, and the family found he to be in altered mentation. On examination in the ER, he found to have an altered mentation with GCS dipping. There is no guarding and rigidity in the abdomen. There is no neck rigidity as such. The pressures were dropping to 80/50. The patient was tachycardic with 165. He's hypoxemic with 82 on a room air, needing oxygen supplementation. He's tachypneic with 34, and is icteric. So as we generally define these cases to be sick with high-grade fever and abdominal sepsis, this patient was cultures were sent and initiated on antimicrobial, suspecting some possibility of a tropical fever. Doxy was considered, IV fluids given, NORAD initiated to actually maintain the perfusion. And there too, this patient also required a sled to support his renal system because it was anuric. And this patient still has a very high NORAD, vasopressure, and maybe switched on to needing an adrenaline also. The patient's conditions were worsening, procal was high, the cultures has shown no growth in the last 24 hours, and TLC count was high. So this is not an uncommon situation which we come across. But if you look at this whole situation, this patient had a fever, this patient had a tachycardia, this patient had a tachypnea, and which all fits into a SIRS criteria with a suspected infection because the patient had an abdominal pain. So, and you adding to that, you have a leukocytosis, you have a procal high, all this probably adding to your confirmation that this patient. But two, common surprise that many of these patients, when we do see CT abdomen, we do find these patients to have something which is not infective. For example, if you look at this patient's CCT abdomen is suggesting a severe pancreatic necrosis or a pancreatitis. So what we are trying to say, or what I'm trying to emphasize, is systemic inflammatory response syndrome, that is fever, tachycardia, tachypnea, leukocytosis are systemic inflammatory response. They cannot be just taken as a signs of infection. They can happen not just only in infections, but they can also happen in inflammatory conditions like trauma, burns, pancreatitis, and other situations where there is a tissue injury. For example, a post-surgical situation. Wherever you have this tissue injury or inflammation, you may have a systemic inflammatory response syndrome. So not all fevers, not all tachycardias, not all tachypneas or leukocytosis are infection. You need to keep this in mind. So we will come back to this later. So just to have a funnier side of it, not all fevers are a sign of antimicrobial deficiencies like ceftriaxone. You need to keep a watch on why there is a fever. So if you come back to for this definition and understanding of sepsis, this has gone through a multiple layers from 1991, where this sepsis has been defined with a SIRS criteria with a suspected infection. over to 2001, where there were criteria set in for general parameters, inflammatory parameters, hemodynamic parameters, organ dysfunction parameters, and on so on. But the latest one, which I will come across, we only say if the infection is to a local site. For example, it is confined to a respiratory tract, if it is confined to a urinary tract, if it is confined to a skin and soft tissue, we always tell them it is an infection. We say a respiratory tract infection, cellulitis, or a urinary tract infection. But if that infection causes a damage to an extent that it creates a dysregulated host immune response, that leading to different organ system involvement. For example, in this case, where we have seen from sepsis 2 to earlier definition, now we are saying there is no sepsis where we are saying SIRS criteria with any suspected infection. We are saying sepsis is an infection with organ dysfunction. The other all form of infections we consider as a simple infection. If the patient with the infection now having an organ dysfunction, we call them as a septic condition. And if the patient with organ dysfunction also have a hypotension, we call them as a septic shock. I think I'm clear. If the patient with an infection started showing organ dysfunctions in the from head to toe, if I have a patient with suspected infection or a confirmed infection having an altered obtundation of sensorium, if the patient has hypotension, if the patient has hypoxemia, if the patient has oliguria, all this indicates there is an organ dysfunction happening. So in this situation, I will define them as a sepsis. Earlier, this was considered as a severe sepsis. Now we are no more calling them severe sepsis. All those patients who has organ dysfunction are calling sepsis. If the patient has no organ dysfunction and has only local infection, we are treating them and leveling them as a sepsis. There is a reason why this has been focused. See, if a patient has a simple infection, the expected mortality in them are close to zero if they don't progress into any form of sepsis or septic shock. But if a patient has an organ dysfunction, even a single organ dysfunction, the mortality starts rising from 10% to 30-40%. If a patient from organ dysfunction lands to a septic shock, the patient's mortality goes between 40 to 60%. So there is a change in the outcome. So the simple infectious patients may not need a close attention, but the patient with a sepsis may need attention. Septic shock may need an emergent, urgent attention. Then I used a term called dysregulated host response. We all know our immune system protects us. Any foreign invasion of a bacteria, virus, or a protozoa into our body has been protected by your immune system. But when our immune system overreacts, we say it is a dysregulated immune response or a dysregulated host response. That dysregulated host response, the cytokines, chemokines released from this dysregulated host response also can cause organ injuries. So basically, when we say sepsis, it is about infection leading to organ dysfunction. Now, coming to how do I define an organ dysfunction? We will come to that, how we define organ dysfunction, but it's a pictorial depiction that whenever we see a patient having a low PF ratio, hypotension, oliguria, we define them as an organ dysfunction. There was a concept to simplify this, saying in a out of ICU setting, in a out of emergency ward setting, in a ward. So can we have a simplified version of this so far where there is no labs involved and the clinician can guide us that this patient is probably having a sicker patient and having a sepsis. So if a patient had a suspected infection and if the patient shows any of the three, like altered cognitive function, tachypnea like respiratory rate more than 22, or systolic blood pressure less than 100, if any two of them are present, we used to tell them as having a quick SOFA, Q SOFA being positive. And these patients are considered as a sicker group, needing a more close attention in ICU. But this has been later, from 2016 to 2021, in the 5 years, has been criticized, saying that the Q SOFA may give us a predictability of a sicker state and mortality, but not all septic patients will be in that 6 days. So the sensitivity of Q SOFA was considered to be low. So in 2021, the surviving sepsis guideline recommended against use of Q SOFA compared to the earlier scores like SIRS or Muse as a screening tool over this QSOFA. So this is a change in the concepts of the QSOFA being earlier used. Now we are saying probably QSOFA sensitivity is extremely low, so we cannot use as a screening tool. Then, as I told, the sepsis-related organ failure assessment will be using a SOFA scoring system in an intensive care unit. And the SOFA scoring system includes a PF ratio in an ABZ and hypotension and a blood pressure equipment, drop in platelets, drop in GCS in the form of Glasgow Coma Scale, increase in bilirubin, increase in creatinine or decrease in urine output. All this will be considered as a score in a SOFA scoring system. If there is a change in more than 2, along with a suspected or a confirmed infection, we consider them having a definition of sepsis, and these patients will be included in the sepsis flow. So to simplify, a confirmed or a suspected infection with more than 2 SOFA score, we tell the patient to have a sepsis. If the same patient is requiring a vasopressor or a volume or a lactates are climbing up more than 2, we level them as a septic shock. With sepsis, there is also a shock. So the QSOFA and SOFA will be useful for predicting the mortality. The more the score, the more the mortality. But there was always a concern about its sensitivity. Let us go through one more case. A 27-year-old boy came to our emergency room with a high-grade fever with chills and rigors for the last 5 days. This patient had a dark color urine initially and slowly started dipping urine output. And the patient presented to us with breathlessness and altered mentation. His HRCT initially showed some small GGOs here and there, and this patient turned up during our COVID period, and there was some chloride 2 was suggested. And this patient's GCS was E3, V4, M5, dipping from 15 to 14 or 13. No neck rigidity found. This patient was again hypertensive, tachycardic, hypoxemic, and icteric. So again, this patient was continued to receive all those antimicrobial as a protocol. Blood cultures was shown. And to our surprise, this patient was receiving both meropenem and doxycycline as an initial cover for tropical fever and all. But we got a call from our pathology department saying this patient's peripheral smears looking like joints of falciform, Plasmodium falciform. So the message is sepsis is not always due to bacteria. As I said, systemic inflammatory response syndrome is not always due to infection, but also due to some inflammatory conditions. In the similar way, sepsis can be due to not just bacteria, which may be predominant, but this can happen with parasites, it can happen with fungus, it can happen with viremias, and any other infective agents. So whenever a patient with sepsis and organ failure comes, we need to keep those things open. So just to give you overview, we also see in this monsoon season a dengue fever. You can just see how sepsis presents like a dysregulated host response when the patient is sick with a leaky capillaries and causing a lot of peripheral edema and all. Similar way, a dengue shock syndrome or a severe dengue patient with warning signs may present in the same way. So dengue fever causes dengue sepsis. In the similar way, if you look at the COVID, during the COVID, how actually the systemic inflammatory response or you say dysregulated host response caused a lot of havoc. One side we spoke about more aggressive innate immunity, dysregulated B cell response causing a lot of cytokine storms. The other side we spoke about dysregulated T cell dysfunction, which actually had a T cell deficit causing immunosuppression or immunosuppression. So whenever we say dysregulated B cell response with cytokine storm, we try to use immunomodulators in them, like IL-6 inhibitors and all. Whenever we saw T cell activation is a problem and the patient is going into immunosuppression, we try to give some T cell activation. So what I'm trying to say, sepsis is a syndrome which actually initiated by an infecting agent. Either it can be bacteria, virus, parasite, or anything. But over a time, when these insulting agents enter to the body and causes the damage to the tissue, the host reacts to it by an immune response. And it also depends not just an insulting agent, but how your host responds to it. If the host responds very violently with a dysregulated manner, that itself can cause multiple organ dysfunction. Why I am saying this is the same dengue virus attacks hundreds of population. But when they come to the clinical presentation, one patient just has a 4 or 5 days of fever and recovers. The other patient lands into a severe dengue shock syndrome, multi-organ failures and death. So if the virus is same, the load is same, why do one patient behaves on one way, the other patient behaves on the other way? Probably the reason is how your host regulatory response or immune response react to it. So this has been a phenomenon in many of our COVID patients from asymptomatic stage to severe cytokine storms. Okay, coming back to the basics. Suppose I diagnosed a patient of sepsis. I'm suspecting an infection. Initially, I may not be always 100% confirmed, but I am suspecting an infection and there is a source for it. Maybe my idea will be I have to look at the source. If it is a central nervous system, like a patient who is coming to you with a headache, high-grade fever, neck rigidity, altered sensorium, seizures, I will suspect a source to be the central nervous system. If the patient had a productive cough, breathlessness, and chest discomfort, chest pain, and an X-ray suggesting some pneumonia, I will probably consider this be a respiratory tract infection. If I have a patient who says renal angle pain with decreased urine output and pyuria, probably I will suspect it a urogenital tract. And if I have a patient who has an abdominal source like biliary sepsis, appendicular, or a bowel perforation, I will say abdominal source. So if I have a patient with suspected infection with septic sign and a focus, sometimes we identify focus, sometimes we may not able to identify focus, and I diagnose them as a sepsis patient because they have organ dysfunction, then my 1 hour bundle starts. I need few things which need to be done very quickly. What are they? After I initiate a septic bundle, after I take care of airway breathing circulation, optimizing airway breathing circulation, because I hope all of us follow that. Then the specific things which we look at is first is take a ABC and look at the lactates. If you have a ABC machine, if your lactates are more than 2 or more than 3 or 4, you are looking at a low perfusion state. Obtain a quick cultures, appropriate blood cultures and any source cultures like urine or any pus or any site which you think is appropriate. And then administered broad spectrum antimicrobial. And then if the patient found to have a low blood pressure, low perfusion state, you try to give a volume. The volume ideally is recommended is 30 ml per kilogram. That is, if I take a 60 kg patient, it will come somewhere around 1.8 liters to 2 liters. So 3 to 4 pints of crystalloid solutions if my lactates are high, if my patient has a hypotension. And then if the patient still is not improving on the blood pressure, I will consider a vasopressor agent to maintain the blood pressure more than 65, map of more than 65. So these are the 5 things I will do. I will look at the ABC and lactates. I will take appropriate blood cultures. I will give an appropriate antimicrobial according to the site and the suspected pathogens. I will give volume if the patient is hypoperfusing. I will probably use a vasopressor to make the patient's perfusion intact. So there were different recommendations. Initially, we had a good recommendation for 30 ml per kilogram. Over a time, we have realized that because of a lot of awareness, volume overload being a major challenge right now. So even though we give a 30 ml per kilogram of initial volume resuscitation in a hypertensive patient, there is a recommendation that you see the volume responsiveness by different modalities. If you have a ultrasound at the bedside in your emergency room, look at the IVC to see whether it is a full or empty, whether the patient can take further volumes. See, many of these patients can be a CKD patient as a severe heart failure or decompensated cardiac patient. These patients may need more attention when you are challenging them with the volume. The second thing in this recent 2021 guidelines is they have actually talked about a capillary refill other than lactates. What is a capillary refill? You actually give a compression to the tip of a finger for 5 seconds. You count 1, 2, 3, 4, 5 and release, and see what is the time it is taking to rebound back the perfusion in the pink color. If the rebound back is less than 2 seconds, we say it is normal. If it is more than 2 seconds, we consider it as dehydrated. If it is more than 3, we feel the perfusion is slow. And if the delay is happening more than 5, we are in concern situation. So capillary refill has been used as an alternative to peripheral perfusion. If I don't have a lactate, probably capillary reperfusion has been shown in few of the studies that it can be used as an alternative modality to use or to understand my perfusion. Again, if you understand the topic which I'm talking about today, it is all not about management of sepsis, but the awareness to create that sepsis also kills and harms the patients and the organs as like a myocardial infarction. If you must be understanding, if somebody gets a chest pain and an MI, there will be a code activated. The patient has an MI code MI, and there will be a lot of clinical pathways which will be kept actively. And many families and even clinicians get very alerted when the moment you say the patient has a heart attack or an MI. In the same way, nowadays we are seeing a lot of awareness about stroke. If a patient gets stroke, we always say time is neuron, so we need to protect, and the whole corridor will be emptied. The patient will be wheeled down to an MRI, thrombolysis, all will be done. In the similar way, we need to understand that septic patient who are in organ dysfunction and hypotension, if we don't act appropriately in quick time, we will lose many of the organs and the outcomes and death will be extremely high. So we need to understand this and probably start talking about a sepsis code, activate a sepsis code, and you also need to understand that time is a tissue in many of these septic conditions. So these are the different formats. Know the signs of sepsis, save a life. You use a time mnemonics like temperature, signs of infection, mental declination, feeling extremely unwell. So these are all signs if you have suspect sepsis, and try to respond to this sepsis timing. So be vigilant about sepsis. If you have a patient whom you think that this is a patient who has a sepsis with an infection, and the patient is in organ failures and hypertension, try to recognize it early. Alert the team if you have a sepsis code, or your critical care team, or the primary team under whom the patient has been admitted. And as I told, appropriate antimicrobials initiated as early as possible. At the within an hour of time, the patient should receive appropriate antimicrobial, and the patient need to be optimized ABC wise and hemodynamically. The other important thing after this initial 1 hour of bundle is source control. And we will talk about the source control later. Just to simplify the management of sepsis, if the patient is hemodynamically stabilized, keep monitoring lactate, give IV fluids and vasoactive agent appropriately, and use hemodynamically stabilized by giving IV fluids and vasoactive agent. If the infection control and infection detection and control, the source of infection to be detected and need to be controlled, and this has to be done by appropriate cultures and antimicrobials and source control. Coming to the source control, which is equally important, that is the drainage of source. If you have an intra-abdominal sepsis, if you have an empyema, if you have a pyelonephritis, if I have a acalculous cholecystitis, I have to put a drain and drain them. As long as you don't control the source, you may be doing miracles with your many other areas, but patients will not improve. You have to control the source. You need to probably debride the infected necrotic pancreas with source. You may probably do a surgery intervention in a abdominal surgeries. You may need to remove a vascular catheter which got infected, or a urinary catheter which got infected. You need to remove any intrauterine devices or any prosthetic devices which are in place. And probably there has to be a definite surgical intervention in case of a gangrenous infected and or a amputation in a case of a Clostridium myonecrosis. The source control will be very important. If I am not doing a source control, the patient may initially show some response by your antibiotic and vasopressors and your resuscitation, but in no time the patient will again dip down and will die. So source control remains to be a paramount important. Probably the exception for source control will be pancreatic necrosis debridement. At this point, we are not be very aggressive because pancreatic tissues are very deep inside. We try to do the pancreatic necrotic debridement by a less invasive draining system, by a CT guided draining or a minimal invasive draining by interventional radiologist, not opening the abdomen, because opening the abdomen and debriding them has shown to have an increased mortality. So this is again the over the simplified version. If I have a sepsis with septic shock, I will use vasopressors to maintain my blood pressure more than 65 and targeting my lactates. So these are the protocols which we do: antimicrobials, volume, vasopressors. The sequence of vasopressors are norepinephrine, vasopressin, and in some of the times where my SCVO2 is low, maybe I will consider dobutamine. If my vasopressors are not helping, I may consider epinephrine. Steroid generally we don't use in otherwise hemodynamically improved patients, but if my patient's blood pressure is still not maintaining after all these vasopressors, I may consider a stress dose of steroids, and those stress dose of steroids are around 200 milligrams of hydrocortisone in a divided doses, that is 50 milligrams QID or a 200 milligrams to 300 milligrams over a 24 hours infusion. So traditional approach is antimicrobials, fluids, vasopressors, steroids. And again, believe me, after 3-4 days of this patient stabilization, many of these patients will be in a volume overload state because we have given a lot of volume to make these patients hemodynamically stable. So antibiotics will continue. If the patient's hemodynamic are stabilized, drop the IV fluids, make the patient take enteral feeding, and probably slowly taper vasopressin, norepinephrine, and you can also consider some of the supplementation of elemental electrolytes, or in the form of thiamine or some of those micronutrients. So this is again a nutshell, all of them together. Antimicrobial, early appropriate antimicrobial has made a big difference. Fluids or crystalloids are the choice. We are nowadays avoiding most of the colloids. If I at all use a colloid in a patient who is having a lot of leak, probably albumin will be my choice. Early targeted goal-directed therapy of SCVO2s and lactate clearance has no more been validated, because many of the recent trials has not shown that a target goal has shown to be helpful. Vasopressors of choice, as I said, are norepinephrine is the first, followed by, if the patient is not getting better by norepinephrine, epinephrine can be add on. If my patient is requiring higher dose of norepinephrine, I will add vasopressin. Always feed these patients. Enteral feeding will improve the gut integrity. And glucose control, probably we will not go very tight control, but somewhere between 140 to 180 will be our target. And whenever we ventilate this patient, we always try to use a lung protective ventilation, and probably a urinary catheter. Monitoring urine output will be a poor man's cardiac output in many of these situations. So with this, I think I try to comprehensively covered everything in this short time. This is a vast topic. I would like to take questions, and I take my all greetings from this biggest unit in the high-tech city from which I belongs to. This is a 2,000 bedded unit which I belongs to. Thank you. Over to you.
Thank you so much, sir. Thank you so much for your wonderful talk that you have delivered today upon this topic. It's such briefly you have described everything upon this topic. So thank you so much for that. We have received 2 questions from the participants. I would like to put it across to you.
Yes, please.
The first question is, what are the home-based sepsis education fosters prevention?
So yes, so as I told, we need awareness. Okay, so many of our community or many of our even own family members, if you talk about myocardial infarction, heart attack, they will be really bothered and worried. If you talk about any stroke or paralysis, they will be worried. But many of them will not be aware of this term called sepsis or sepsis signs and symptoms. So I think as we understand, this is one of the important cause of mortality in hospital settings. We have to pick up them early. See, many of us will have one or the other infection length and breadth of the year, like we get respiratory tract infection or urinary tract infection here and there. So what actually we need to keep this community aware is any of these patients who had any kind of infection, either respiratory tract, urinary tract, or any, if the patient has any clinical signs of any organ dysfunction, like if the patient is having not feeling well, is unwell, they need to be attentive. The patient has altered sensorium. If I say, if the patient is drowsy, delirious, irrelevantly talking, a elderly patient, irrespective of the cause, you need an attention of medical personnel. In the same way, if the patient is breathless, if the patient is cold and calming, if the patient's urine output has been dropping for a couple of days or so. So these are the signs which suggest the patient's organs are not working. And so what we need to probably convey to the community is any infection which has a sign of seriousness and you are not well, you need a medical attention, and that to be done earlier. Then you wait for those organs to get lost and then you go to a hospital. I think that's the community lessons which we have to carry. And sepsis should be also a known phenomenon to many of our communities. Hello.
Thank you so much, sir, for answering in this question. We'll move to the next question that we have received. And the question is sepsis reversible?
Yes. See, if you ask me, day in and out, we see this septic patient, and we get patients from other referral units who are on multiple organ supports and on ventilators and on multiple inotropic and vasopressor supports. And believe me, if we have a good source control, a team who actually monitors these organs and give appropriate antibiotics, even I say 60 to 80% of these patients survive. And more interestingly, many of these organs which they actually go into a dysfunction will recover. So sepsis is a reversible phenomenon, contrary to a stroke where if your neurons are dead, they are dead for life. If a myocardium is gone, they are gone for life. But in many of the times, many of these organ dysfunctions recover well. So it is a reversible condition. So that's more so reason that we should focus on this reversibility.
Thank you so much, sir. Thank you so much for answering this question. We'll move to the next question. And the question to the next participant is, what causes sepsis primarily?
Most common cause is bacterial infection. See, in many of the times when we see patients in ICU with multiple organ dysfunctions, most commonly we see gram-negative and gram-positive bacteria which cause them. If you talk about meningitis, where CNS is involved, probably a gram-positive cocci are more common, gram-negative cocci gets involved. When you talk about a lung, we see a gram-positive cocci in the bacteria are involved. So overall, in general, bacteria are the most common cause of sepsis and severe sepsis, but it is not always the bacteria. We see fungal infections, and fungal infections are more common in immunocompromised situations, like somebody is receiving immunosuppressant drugs, high dose of steroids, or some immunomodulators for any rheumatological issues or for any hematopoietic stem cell issues. So these are the situations where fungal infections also will be more prevalent. It is not that fungal infections are not possible in immunocompetent, but it is more common in immunocompromised. Viruses, as we've seen COVID, for the last 4-5 years, we have been struggling with this pandemic. So COVID has shown us that how a virus can cause so many spectrum of septic illnesses. So from a milder to a severe COVID sepsis. So similar way, we see dengue can cause dengue sepsis and organ failure. So even though viruses, protozoas, fungi all can cause sepsis, most common is bacteria.
Thank you so much, sir, for answering this question. We'll move to the last question. We will take the last question for today's session. And the last question for today's session is, what are the risk factors of sepsis?
See, ideally, we assume that many of us who are immunocompetent and we get some local infection, our body will be competent enough to fight it back and probably control that sepsis at the local site. Okay, that's what our assumption is. But sometimes if the the infection is severe and it invades into a deeper tissue, and we ignore it for a good period of time without appropriate treatment or antimicrobials, these can lead into organ failures and further deterioration. This is one area if we ignore, and even in an immunocompetent, normal, healthy individual who has actually a good load of bacteria inside. For example, we do get some food related ingestion of bacterial load. Sometimes some injuries also causes deep bacterial inoculation into our deeper tissues. So these are the, even immunocompetent host also can get infection if there is a bigger load of bacteria or other organisms which go into our body and we ignore them. But other high risk patients are diabetic patients. If a poorly diabetic patient come across even a local infection like a trivial injury, that can lead into a severe sepsis and organ failure. So diabetic will be on a higher risk. Similar way, a immunocompromised patients like ethanolics and like a elderly patient, a smoker, and a patients who has receiving some immunocompromised drugs, a retroviral patient, a patient with some malignancies for which is taking chemotherapies, all these patients has a higher risk of deterioration from a simple infection to a severe infections, or somebody who has a transplant and receiving immunosuppressive therapy. So these are the patients where we have to be more careful. As I said, local infections may be simple in many immunocompetent hosts. Suppose I have a respiratory tract infection, urinary tract infection, I may just take a home remedy and keep a monitoring with symptomatically, or I may visit to a local physician or a family physician to take the follow-up. But in case if I am a immunocompromised host, a post-transplant, or a chemo patient, or a patient who is on some amount of immunosuppressive, or a diabetic with a poorly controlled, I will be more prone. So I probably I will request, or I will suggest or guide them. They have to be in a high alert, and they need a quicker and more alert medical attention than otherwise a healthy individual.
Thank you so much, sir, for answering all the questions. That was the last question for today's session. And at the outset, I would like to thank all the viewers who were here with us for their ardent participation that they have shown, and for the patient listening, of course. And with this, I would also like to thank you, sir, for taking out your valuable time and for being here, sharing your knowledge with all our viewers who are here present with us. We hope that this knowledge that has been spread by you will definitely help them in their daily clinical practices. So thank you so much, sir. Thank you for that. With all your last comment, we can conclude the session here for today, sir. Until next time.
Thank you. Thank you.